All right. Well, good afternoon, everyone, and thanks for joining us. I am Zach Kacharski, the executive editor of the Gazette, and I'll serve as the moderator and question asker in this session. Joining me is the director of Health and Human Services, Kelly Garcia. And for folks, this session is live. We are virtual, of course, but we will run with the opportunity for questions to be asked through the chat, and I would encourage you to do that. So if you have a question, you can submit that and it will be forwarded to us. And so I told Director Garcia just in the couple minutes of prep time that I wasn't going to read a full bio. And so Director Garcia, thanks for joining us today.
My pleasure. I'm glad to see you.
Well, it's good to have you here. And obviously you've been fairly busy. You have a new department. At one time it was public health and the Department of Human Services. And so I guess from jumping off at the 60,000 foot view, and we'll dive into the parachute will open and we'll go into more depth, I guess. But talk a little bit about this organizational change and what does this mean? And both internally within the organization, but for Iowans as well.
I think that's a great question, a great jumping off point. So when I arrived in Iowa, I immediately started to assess for big topic areas like maternal health and behavioral health. What's our vision in the state? Kind of get me up to speed. I'm learning here. I need to listen. And I really wanted to think about how the intersection of the legacy Department of Public Health and the legacy DHS worked with each other on these bigger strategies, knowing that at the Department of Public Health, they were working on substance use and maternal health strategic plan. And over on the DHS side, we had the Medicaid program. And that's a huge lever in some of these big topic areas. We also had mental health and disability supports and working with our MHDS regions. And what I found were some significant gaps in that strategy. In fact, in some areas, lack of strategy. And that's not me saying that we didn't have really great team members working on these very important topic areas. But what we lacked was a real integrated approach to thinking about how we serve Iowans, kind of in totality. Really thinking about, when an individual comes in a door, often needing help, right? Not on their strongest day. How do we create an approach to offering them, here are the supports and services we have. Here's what we know you need through a human-centered approach. And if we don't have it within our own span of an agency, how do we give you a warm referral out to another space? And so we really started to think about that approach. That's what kicked off the dialogue. And I think in my discussions with Governor Reynolds, as Director Claybaugh announced that he would be retiring, she asked me to go serve in that capacity and really assess, should these agencies merge? She gave me the space to give her that independent analysis. And ultimately, it was my very strong recommendation to her that we do. The legislature contemplated that last session and then created our new agency. And we are actively engaged in kind of the mechanics of putting those pieces together. For the team, well, I think it matters who you report to. It matters that you set a vision and that every day in this very big system, we're driving on change. We're actively analyzing and using tools like our epidemiologists who work on population health. And we're thinking about those metrics and those data that help us drive on change, and handing that over to client service functions like the Medicaid program, or even all the way into our deep in system work like child welfare, help us better serve all Iowans.
I'm curious. I mean, this is not a small agency. I mean, you have 5,800 employees, and I think the Medicaid program has somewhere around 800,000 participants in it right now.
More than 800, yes.
Yeah, and so I mean, in some ways, you still have to fly the airplane and rebuild it at the same time.
Mm-hmm.
How are you going through, this transition on the front line? And, what is your timeline for kind of, these adjustments and really functioning as the new department?
Certainly. So there was a very intentional path here, and we've been engaged in this work for more than a year and a half now, thinking about the assessment, how the programmatic functions come together, and then receiving a significant amount of stakeholder engagement and internal feedback from our team members about how the day-to-day operations really need to intersect. where there are gaps, where we have spaces to improve. And all together, that created a functional org chart that we launched back in the spring around the March timeframe. Again, the alignment website that you just put in the chat, you can see the history of how all of this has evolved. And then over the summer, we started translating that functional org chart to a table of organization. And up until last week, as I made some final tweaks to the 2 last divisions that don't have a leader in the space quite yet, because we are so significantly changing that work, I had not made a single change to the org chart. It was completely led by our team and the incredible amount of stakeholder engagement that we've received over this more than a year. That's what success looks like for me, right? Is really engaging, bringing the people who do the work and who we partner with to do the work to the table to help craft an organizational structure that allows us to drive home on really solving these big subject matter areas, while really getting down to the kind of brass tacks of improvement. And you have to do both and. So that's really been, it's been a challenge, certainly. But this is really creating an organization of continuous improvement and charting out exactly from an operational detail perspective, how we get there and do that work every day to achieve those goals.
Yeah, I was curious. See, when you think about public health, that's an organization that's been focused, on tracking trends and things over time. And then, DHS kind of had a different set of metrics and measurements that they would use or data that they would use. Do you think bringing these together will help on a policy standpoint in terms of being able to, pivot in closer to real time, where and I'm not leveling this as a criticism about, but sometimes government has the reputation of being slow to adjust. Do you think that bringing these groups together will be more responsive from a policy standpoint?
Absolutely. So data is a huge piece of that. And when you look at, if for those of you who might go into the alignment and the transition plan, the alignment website or the transition plan, you see embedded a new refocused mission, vision, and value structure. And embedded in that value structure are a few key things, a few key points, right? The way we do our work every day, and data is at the top of that list, right? We have to be using data. Our agency is home to huge amounts of data sources, some that do lag, to your point, and it just can't be real-time. Claims information is a good example of that. But we're also actively building out data systems that allow us to better see real-time information. Our syndromic surveillance system, led by our partners in the public health discipline, our public health vertical of our new agency, will be able to tell us if there are clusters of overdoses in real time, where we can alert medical providers, teachers, law enforcement, and EMS to be equipped with Narcan or to have other intervention strategies in real time to respond to that emerging need in a community. That's one, I think, very crisp example of the type of work that we're really focused on, but there's no shortage of those types of examples.
I was curious, just in reading the report on the realignment, in the transition report, it mentions that there are thousands of places in the code that'll need to be reworked in the coming session. And, that sounds fairly, fun from a policy standpoint, I'm sure. But I'm curious, what other changes legislatively are you going to need to make this a reality? Are there things that heading into the session, the lawmakers came together last year and gave you approval to go off and do this? Are there other pieces of legislation that you're going to need in the coming session?
So I think of 3 key points. You just named one of them, which is our recodification bill. So we worked on that over the summer as well. We have the bill drafted. It's really technical cleanup, naming change conventions.
Yep.
The second is more substantive, right? And that is the legislature contemplating whether the Department on Aging should move into our HHS structure. And when we think about the connection points with our partners over in that department, I actually just came from meeting with them in a staff retreat. We think about the connection between our guardianship program and adult protective services. Those are separated by agencies today. There's a lot of opportunity to bring that work closer together. And nutrition is nutrition, right? And thinking about how we feed and have culturally appropriate meals for different populations. That's embedded in some of our equity work, right? So there's just a lot of better informing that approach that I think our two agencies can offer each other as we work. And then there are, of course, the big ticket items like Medicaid diversion, keeping older Iowans at home in the community of their choice, right? Whatever home looks like for them, and out of spaces like nursing facilities, unless we absolutely have to use that institutional setting. And there are times when we do. And that is an integration with the Medicaid program. And we're already working on some of those pieces, but there are bigger and I think pretty bold strategies for our state to tackle. And we'll do that together. The third is around the way that we get input from our outside entities. So in DHS and public health, just those two agencies alone, you'll see this in the addendum to one of our original reports. There are 6 pages, 86 independent organizations that give our agency, or me specifically, the director of the agency, feedback around how we do our work. 86 is a lot. And that certainly is not me saying that I don't want external feedback. I do. I welcome it. We've embedded that into our work, a commitment to transparency and bringing our partners to the table in our decision making is in our guiding principles. And I truly mean that. But hosting the 86 meetings on a quarterly basis with team members, we're not really getting the level of mature feedback that I would like to see. And so that's the third piece. And I don't know that that comes this session because we're doing some evaluation that may take us longer, but I'd like us to really think about a more mature kind of methodical strategy around how we as a big organization get outside feedback from disciplines and consumers, members with lived experience who can come and tell us in a way that they can also see their input being taken by the agency. It's hard to do with the volume that we have today.
I was going to ask, and as you're talking about some of that outside feedback, I mean, some of these are appointed committees. And so, how are you going to go about kind of figuring out what that feedback structure would look like? Because in some regards, that's the opportunity to be at the table.
Absolutely.
And so how are you going to go about that?
So step number one is ask them, right? And we've done that. We just recently sent out a survey to a number of those boards and commissions to ask them, do you feel like, what is your purpose? What do you see your purpose as? Here's what the code says, but do you think you're doing that? And that's not a trick question, right? But do they feel like they're actually able to achieve what they've been asked to do? They're taking volunteer time too, as well. And so we want their experience to be meaningful. And then asking them, what strategies do you see to kind of achieving a better seat at the table? And so that's step one. We're just gathering that right now in real time. And we've received some really interesting feedback. So asking folks who serve in different capacities to help us craft this has been a part of the strategy along the way. As I said, it's embedded in our guiding principles. And so we'll just continue to do that work and see where we land.
Okay. You mentioned the Department of Aging and maybe that coming under the umbrella, but also there's some other programs kind of within other agencies as well that are coming over. Is that, some, maybe I misread that in the report. I thought there were some programs that were housed in some other departments that around needs assistance and things that were maybe coming under the Health and Human Services umbrella.
So we're certainly thinking about broader connections, again, around that front door entry point. But right now, we don't have any plans. We're kind of assessing, right, those connection points. But right now, we're pretty well solidified with aging coming in.
Okay.
The legislature has to contemplate that move.
Now, just this week, you've talked about kind of those two final divisions, the family well-being and protection and community access. And can you talk a little bit about the focus of each of these departments, what'll be under and how do you see these working or playing off of each other?
So they are huge moves. And Zach, as I was thinking about your question, I think you might be talking about rent reimbursement. So rent reimbursement is coming in. It's coming in from the Department of Revenue. And that is an assistance function. I mean, it is exactly what it sounds like, right? That will be a complementary focus in terms of an economic assistance for families who need some help kind of getting back on their feet. So you're absolutely right. And I'm sorry, it's so deeply embedded in our
don't worry.
I forgot.
But yes, a bit more specific.
And some real enhancements there, because it has historically been a paper-based process, and now we're integrating it into an online solution, which is great for our workforce who are doing the determinations, but also great for the consumer who don't have to come to the Hoover building in Des Moines to hand off their application any longer. So some real efficiencies there, and that's the type of work we're thinking about in this strategy. But back to your question, so how do they fit together? Well, this is the space in our organization that is actually receiving most of the change and movement. So one, in building out the community section of the agency, what we're doing there is back to rent reimbursement. It's the one front door entry point. So today, our work, our policy work, when we think about who's eligible for what types of things and how we strategize, are in different sections of the agency. And so that makes it hard. No one person is thinking about the cliff effect, right? If I take a promotion in my job, what does that kick me off of? And is that promotion less than what I'm receiving on benefits, right? So strategies like economic mobility. How do we equip people to have true economic mobility in our state? This build out really starts to effectuate that change, as well as the mechanics of how we determine eligibility, right? So putting the people who do that work, incredibly valuable team members who are that real like human front door to the work, to better understand what's the portfolio of what's available. And if it doesn't, again, live in our agency, how do we have warm handoffs, warm referrals to outside resources, either at a community level or within another agency, to do that work better? And that's where I mentioned there are other programs, but we're thinking about how to incorporate that, whether they live here or don't. Mm-hmm. And then the last piece is that there's Medicaid adjacent programs. So Title V, Title X family planning, maternal child health programs, and WIC. Incredibly important programs. They're determined for eligibility in a different way than the ones that come through a single streamlined application, but they are part of the portfolio. They're also huge thought leaders that work with their Medicaid program on how we serve low income or at-risk families. And so they will be part of that full community engagement process. And on the family well-being and protection side, what we've done there is create a single office that is dedicated to focusing on childcare. Again, a discipline that was kind of fractured. No one person was leading that effort. It was in a number of different places. We have great team members, but again, thinking about the strategies that allow Iowans to go to work. I am one of those people. I came to motherhood late in life. I still am actively using childcare to get here every day, and thinking about the team members that support our young children for early childhood learning capability and the protective functions that childcare provides as well. And how do we recruit and retain childcare providers in the state? Huge, huge issue of which we are deeply committed to, as well as building out prevention programs and then having a single statewide focus on just child protective services. And these two lines build that out for the first time in our state.
Now, when you have a director, the childcare role that exists, obviously that's of a lot of interest in the business community, and there's been a lot of investment in childcare, stability, and then also expanding with the business community. Are you seeing? I mean, is that some of those touch points that you're talking about, keeping that connection, so economic development connects to the child well-being in health and human services? Absolutely.
So really funneling together, we have licensing, we have childcare assistance, and then we kind of have the broader framework of what is childcare policy, the recruitment, retention of childcare providers, and that early childhood learning kind of capacity. So how are we utilizing that like a pre-K for all type concept, right? And then the connection points to the other agencies that are incredibly important there. And this is really born out of some of our work with the Governor's Child Care Task Force. We, as you just mentioned, we've put more than $500 million into childcare in the state. We're continuing to roll out investments in stabilization grants and other tools that help us learn exactly, how do we better support childcare providers, and how do we realize some of these goals to ensure that Iowa families can go to work, but that we're gaining the benefits of really competent providers as well along the path.
I wanted to ask, in the child welfare piece, there are a couple questions that I've got, and buried in the news coming out of the office this week was the child welfare IT system. Mm-hmm. And IT systems maybe aren't always exciting, but you're in the process of replacing that. And how do you expect, or what do you expect that system replacement to do in terms of the safety of children, and how do you expect to get there?
Yeah. So thank you for asking this question, because you're right. It's kind of it is kind of hidden back here. It's huge work. So we are replacing our case management system for child welfare. And our system today, just for a little context, and I love this example, is a green screen. You can't use a mouse, you have to toggle. And so imagine teaching a social worker who's fresh out of school, who's used to doing nearly everything on these types of devices, a green screen that you can't use a mouse on. Not to mention when we ask him or her to go out and see families, and I want our team members to be focused on seeing kids and supporting families, not doing paperwork in the office, but there's very little mobile functionality. And then on the management side, right, on the kind of responsibility part and the accountability part of this incredibly important work, how are kids safe? I need to see things like, has every child been seen this month? And I don't have that functionality in a very easy way. It's manual today. So our technology will build all of this out in a centralized hub, connecting to the Medicaid program to provide a medical portfolio, and connecting to the partners, including our friends on the justice side, who need to see information, building out portals for foster families to see information, allowing vaccine records to be shared so that, so for the purposes of enrolling in school, for example, practical aspects of this software, but also on the management side, our ability to build out genograms of family history so that we can see who are the children's family, fictive or blood relatives. And what does that look like? Where are they when they move? How do we move them? Like a real picture of what this child, our youth that we serve, look like. And that we can print that in a compendium of who they are and see them over the course and trajectory. You know, there are lots of families where we interact, we close a case, we open it again. I want to be able to see that. And there have been some very high profile cases in this state where the IT system was a key barrier for our team members even to being able to see that true span of a child's life. And then management controls, again, really clear ones. Like you go out to see a youth, I see the youth, I engage, I take a photo of the youth, it's time stamped in my phone, it's immediately uploaded to the system. And then I have assurance as the director of the department that all youth have been seen, we've done our visits, we've timely filed our reports, and work is good. And there are no shortage of functionality that we can leverage in terms of technology. And this is a win for all, right? It allows our workers to have an easier way to do their very important work, focusing more on spending time with families and doing the social work that they are trained to do and not bogging down in paperwork. So huge, huge changes afloat, huge. They start to come online in the spring.
That is pretty quick. So there's a lot going on.
There is.
I wanted to ask also about, you announced this week the intent to award a Change and Innovation Agency a contract to assess the child welfare practices and policies and how it impacts the outcomes for kids. And I'm curious what the intent behind the review is and what made you feel that it was necessary at this time. So
I have worked in child welfare in different capacities for a long time. And it is a complex set of work to make it, to make all systems go and to really successfully achieve both protecting children and having the best interest of children at heart. And we have a number of different players, not just our own work, that makes that happen, right? Our intersection, again, with judges and attorneys, guardians ad litem and foster parents, bio parents and parents who we have a parent partner program for parents who have successfully completed their work in our system and received their children back in their home. And all together, I have, in partnership with the Chief Justice of the Supreme Court, Chief Justice Christensen, and I have been touring the state for the summer, listening to individuals with that experience, including, I forgot to name CASAs in that, but in hearing from them, what are the high points and what are the points where we're missing the mark? This has been an evolution for me in wanting to hear how we do this work better, how we prepare ourselves for the future. Our caseloads are too high in areas. Our caseloads not only need to be brought down, but kind of recalibrated to think about the complexity of family dynamics that exist in nearly 2023. We need to do that to inform our practice. We need not codify a new IT system that has flawed practice. So we have to innovate to get to an IT system that really leverages technology to set us up in the future. So ultimately, in that request for proposal to bring on a group to have an outside assessment, the cornerstone question that I asked is, are children and families better because we're involved? because sometimes in the system, I think the answer is no. We send families and children down a trajectory that doesn't make them better, it doesn't heal them. And I want us always to be doing that work. Our team is committed to that work, but the system isn't set up to achieve that outcome always. And so we're going to do better. We can, and we will do better.
What is the time frame? Is this going to move along the same time frame that all of the other change? Because if you're doing all of the structural change,
all three parts together, right? So the listening sessions are informing real-time work, which is our IT system upgrade as well, which is a multi-year effort. But we're doing design sprints so that functionality comes on board, right? So we're not waiting many, many years to see functionality come on board. Then we do the CPS assessment so that we can better inform IT, but it'll also help me understand how many workers do we need in the system? Are there places where our practice could be innovated in a way that allows us to kind of do less work in some spaces or shift work in different capacity and get to that magic number of what's the right caseload? And I'm interested in things like, should we have specialized case units? Specialized units with lower caseloads that allow us to focus on either children with special needs or really complex system structures, juvenile justice involved kids and the like, those kinds of questions. And then the third part, right, is that we think about, again, a system that has really embedded oversight on a continual basis and allows for that reshaping and kind of real-time innovation. I've been doing that along the way. I didn't just wake up one day and decide to do all this, right? This has been part of a longer-term plan that is just now fully coming to fruition with leadership changes that effectuate that clear accountability and responsibility together so that we really can drive on this mission.
I wanted to ask this, and it's difficult, and it's maybe not a one-size-fits-all answer, but are you expecting the majority of some of these leaders to come from within? Are you going to be looking for some outside the organization? I mean, how are you approaching that?
My very best day is when I get to take a team member who has done phenomenal work and say, you've done that work and you deserve a promotion and you have earned it. So that is the absolute best. But there may be some folks from the outside world who have something to say here too, right? It is a team sport here at HHS. We're not the only people who make this system go. And so I am interested. So it's posted externally, but again, my value is always on my team. I expect there to be a lot of phenomenally talented team members who apply. And those are the best spaces where I get to tap those folks to serve in new leadership positions.
Okay. I have a question that's been submitted, and I warn you, it's a technical one that I don't fully understand.
Oh boy, a quiz.
But I have a sense that it comes from an insider. And it says, can you give us some insight into how the DHHS is linking to the statewide HIE Sync Health and the CIE SDOH system Unite Us?
Yeah, that is very.
Could you translate that?
Yes. Do you need an alphabet soup? Do you need me to break down the dictionary here?
What did I just ask you?
Exchange. So we have partnered with Sync Health in a couple of different ways, twofold way. Right now, we are partnering with Sync Health, which forms an HIE, a health information exchange. We've had kind of fits and starts, like not a great plan in the state around a health information exchange, but at the cornerstone of a health information exchange is to provide data transparency, both to a consumer at an individual level and to those who are in decision-making roles around the way we strategize for rate investments, for example. So both me in my job, as well as the governor and the legislature and others, many others, around real transparency and data that you get when you exchange information. It also provides some real-time data that you talked about in the very first part of this discussion, right? And so we have partnered with Sync Health in that effort. We have done that through some federal funds that the Legacy Department of Public Health received through pandemic. And we are working with our big hospitals and clinics in the state, as well as our major insurers. Medicaid is a participant in this work. We are committed to data transparency. We think that will be best for the state to gain transparency. And a piece of this, right, as we think about data transparency, is really understanding how are we driving on social determinants of health. So that's why you hear the SDOH part of that acronym soup. But SDOH, social determinants of health, are threaded through all of our work, right? There isn't an area of our organization that isn't working on social determinants of health. You think about child welfare, right? That's the deepest end of our system. But we're really thinking about there are family systems and how did that family get to where they are in a vulnerable state? and thinking about social determinants of health are a key component of making sure that a family is stable. So better data around what drives problems and poor outcomes in this state, that helps us solve on that issue. So it is a huge component. And I'm not sure we'll ever really get to true healthcare transformation across the board in the state, or the spaces that we want to see in the evolution of Medicaid in our state without that data transparency. So we are deeply committed as an agency to this effort.
All right. Well, I wanted to ask also, thank you for that. And for the public that are watching, if you have a question, please submit it in the chat and we'll work it in. But I also wanted to switch and talk a little bit about Medicaid, because there's a transition that will be happening in 23 with a new organization joining third managed care provider. And I'm curious kind of where the work stands and how will members be divided between the companies, and information about, keeping current providers, and where are we?
Absolutely. So we are still in an active procurement, right? And so we have to get through some pieces of final stages of our intent to award and actually into the full onboarding. But our team is already actively working with Molina Healthcare of Iowa, DBA, to bring them on board. And we continued our commitment and partnership with Amerigroup of Iowa. And just a refresher and a reminder that Iowa Total Care is on its own trajectory. They have a different contract term. So I'm not talking about them right now because they are on a different term, but they remain committed to the state.
Carry on.
Still very much a partner. So altogether for the three, I mean, obviously through some of the pain points experienced with managed care rollout and onboarding MCOs in the state, we have a number of lessons learned that we have taken. We built it into the RFP and we built into our timeline to ensure that claims processing was ready to go. We had some difficulties with Iowa Total Care's onboarding in that situation, and obviously a lot, like I said, a lot of lessons learned to not have repeat failures. Already having active conversations with providers around that transition. And then also, of course, talking with clients about what that means. In terms of the distribution, we have an algorithm that we use at a very, this is a 60 or maybe 100,000 foot view. It comes about a third, and a third, but it's more complicated than that because we also have to make sure that the risk spread and the profile of members equates and is actuarially sound, as well as we layer on, of course, member choice, right? And so we will give members opportunities to make their selection. But we're working on that actively. No final decisions have been made as we bring Molina to the table and work with their team on making sure that it is very clear to providers and members what this looks like. But that will fall over the summer to go live. You will see us ramp up communication even more than you're seeing it now so that it's clear. And making sure that we really do, again, learn those lessons from the abrasion that occurred in the past. So we have a really deep plan. It is very intense. And our team is already actively working and pointing to this.
And just for total clarity, you're saying next summer things will really ramp up in terms of the members.
That's when the onboarding happens. Go live is aimed for next summer.
All right. And in terms of, the claims issues that happened last time around, and I think there was quite a bit of pain to the provider community.
Yes. What's
being done behind the scenes now to hopefully prevent that this go around?
So a significant, piece of those problems with claims were on our state side in the way we program our system to work with the managed care organization. So we've done some work around that and had some time to do it. But on the MCO side, we're doing more testing, right? I mean, that was the key. We didn't build in enough time originally out of necessity. There were reasons why at the time. I wasn't in the state at the time, but I understand why it was such a compressed readiness review. We built out more time in this procurement phase to ensure that we're doing appropriate testing up front. And we heard from providers loud and clear. I spent many listening sessions hearing from providers. So we don't want anyone to go through that again. And the reason for the third, right, we felt it was compelling. We know that the change is hard, right? This is another change in a space that's had a lot of change. But the commitment from Amerigroup absolutely made sense to continue that relationship for member continuity and to really realize what we want to see in managed care. But Molina had a really compelling bid around demonstrated other state experience in areas that we have vulnerabilities in serving members with long-term service and support needs. And in really thinking about SDOH and a number of other issues. And they're a bit different. They come to this game a bit different in that their work is public payer space only. So they have a lot of, configuration changes that are, I think, going to marry nicely. So we don't see that provider abrasion, but we're testing for it and we're looking around corners.
I have another question that's come in from a viewer. Has any progress been made regarding dentists? We don't have many that are accepting insurance, and many clients are not able to get any dental care at all.
Yeah, great question. So Director Matney is actually, I think, giving a presentation right now at the Community Health Conference talking about dental with a dentist. So Director Matney and I have been working on dental for quite a while. We are not ready to kind of unveil exactly what we're thinking because we're still, just stopping shy of talking about it fully publicly. But we hear you on dental. It is a complex issue. Dentists in the state have received rate increases. We have a shortage of dentists overall, but within our own network, Liz and I are thinking about really bold ideas to better that work and make sure that there is full access and adequacy across the state. So we're very much committed to that conversation, and we look forward to telling you all of that when we're ready to unveil it, and hopefully soon.
Okay. And just flipping back on the provider network, as you bring Molina in, do you have a sense from the provider network how many will opt to work there in that space?
So we're
do
not
you anticipate
quite
problems?
there. I'm sorry.
Okay.
Not quite there to evaluating, but we have commitments, right? I mean, we can see the commitment and partnership happening, and Molina invested a lot of that work in their plan to submit the bid. So we can already see what the portfolio looks like and have assurances there. Now we just need to see the finer point details, which doesn't really start to happen until we make the intent to award. Right? It can't happen until we make the intent to award. And so that's really in motion. But Liz and I will be doing a Medicaid managed care oversight committee hearing in early December in front of the legislature to both chambers come together. And you'll hear from us there about Molina readiness review. In fact, I think you'll hear from Molina themselves about exactly what that looks like. And we'll have a little bit more time under our belts to give you more details.
Okay. And then the intent to award timeline, that would be in the spring?
So we've already noticed intent to award, right? So we just have to get through the protest period.
Okay, gotcha. All right. Well, also I wanted to switch gears again and talk a little bit more about the community providers. And obviously there was the DOJ investigation involving the reasonable cause. The federal investigators found reasonable cause that failing to meet the needs of the services to the residents at the resource centers. And I'm curious in terms of, this transition, you're working at Glenwood to make that change. How are you kind of going through with the residents there to figure out those community settings? Where do things stand? And
well, a lot of intensive work. In fact, I had my regular briefing with that full team yesterday, full leadership team yesterday on our transition plan, right? So we have set the intention to close that facility in 2024. And so we began those conversations, on day one after the announcement was made. And that announcement did not come easily at all, right? The decision did not come easily. We did our absolute best effort to reshape what we're doing at Glenwood, not keep it as is. Our ICFs, which Glenwood is an intermediate care facility for people with intellectual and developmental disabilities, are an antiquated institution. Most states have closed their state-run facilities or reshaped them tremendously, and we're one of the last states to do that really intensive work. So I already had plans underway to kind of reshape it, but ultimately we really are struggling with providing the level of medical care out at that facility that we need to. And so I couldn't, in good faith, look at the guardians or the clients or my own team members in the eye and say, we can do this. We just can't. And so we are on a path now. The good news out of those incredibly hard decisions and incredibly hard conversations, because we have a number of residents who have lived their whole lives at that facility. So hard conversations with guardians and our own clients and our team members who have been so deeply invested, some generationally, at serving individuals at Glenwood. But we've seen a real incredible bright spot through this announcement. We have nearly 30 community providers who have stepped forward to have conversations around taking our members into their community-based options. We are, at this point in time, ahead of schedule for transitioning members out. So a real all hands on deck approach. We've upped our game in terms of thinking about quality on campus and as members transition out. So we are assured that these transitions are to the fidelity of the transition plan itself. They are always person-centered. Many members are focused on staying in Southwest Iowa because that's home. But we also have members who have moved to the clear across the other side of the state. And some who are looking at going to family closer in other states. All together, I think it makes for a really fulsome plan and a deep commitment to all Iowans with intellectual and developmental disabilities to have that same option.
How are you identifying the viable places? Because in some cases, folks have lived there for the majority of their life. How are you going through case by case to figure out, is there a viable support, the community provider? How is this work happening?
Yeah, so you're exactly right. It's person by person. It is indeed person-centered. So the whole interdisciplinary team comes together to think what's best for this individual. The individual's involved, and of course the guardian is involved. So no decisions made without guardian consent. And then once we hear, if and I'll focus on me, if Kelly, what does Kelly like to do? What does Kelly like to live? Where does Kelly want to be? If Kelly wants to fish and live by farmland and be close to Aunt Sarah, then that's what we go to achieve. We look for that. And those are individualized conversations about the person, what the person needs, but then their individualized conversation with the provider network, right? And we have some really incredible providers that have stepped forward and some portfolios from out of state that have come in to do business and are making deep commitments to Iowa that are new. And we've backed that with money that hasn't been there before. And that's a key component of it. So lots of changes in the Medicaid program to support this work.
I was going to ask about that because I saw the reporting that Tony Lays had done for Kaiser Health News, kind of talking about the work that you've done to help raise wages and to hopefully retain more of the caregivers. Is this new work?
Yes.
I mean, and how are you modeling that?
Yeah, so we can't do this work without the workforce. And so we have to, and we can't just, it's not just a strategy about raising wages, although Director Matney and I, that was one of my focal point for last legislative session, was to ensure that we upped the average wage for direct care staff in the state. And that's good for all direct care workforce individuals who support people with all types of disabilities, right? So it wasn't just focused on this issue, but it was complementary and a key part of this successful plan. The other parts are making sure that we have a competent workforce. So everybody wants to get up and go to their job and feel competent in their job. But when you're dealing with individuals and supporting individuals who have high behavioral needs or high medical needs, that level of training, sophistication, and crisis management, if something escalates, is different. And so we have added additional supports for training, added additional supports for crisis response, specific to individuals who have co-occurring mental health and ID needs. And those are all new things. Our programmatic work have never done this before. So it is new.
And I was going to ask, is that limited to the geography of, in Southwest Iowa, or is this something that you're trying to apply statewide?
It is statewide.
Okay. And are you seeing results? Sometimes it's different providers in different areas of the state. Are you seeing interest across the state evenly?
Yes, we are absolutely all four corners of the state and in central Iowa. We are evenly seeing providers step forward, and what our providers needed. That work was always happening, but what they needed to hear from us was a different level of commitment. So financial commitment, support in the training side, and then a commitment. There are some providers who take some of our highest level behavioral needs, individuals who come with a really high level of need on the mental health side, as well as ID supports. And for those providers, what we've said is we will have a commitment to triage those cases before it escalates to the point of a provider saying, I don't think I can do this any longer, right? So we're trying to walk that walk with them. We're early on still, right? We are. But what I tell guardians all the time, what I want our team members to hear, and those who have watched legacy DHS kind of struggle with this in the past, is that we are taking a different approach. The financial commitment is there. That's there from the governor. That comes first, and we have it with our legislature too. We will need to tackle that again with the new members this session, but we definitely have that, and it is different than what the state has done before. It's also more comprehensive, and I think deeper than what the state has approached before. And so that's new, and we'll have to hold ourselves accountable to that work, and we will. But we are seeing promise.
I also wanted to ask a little bit about when you think about the Glenwood facility, at one time that was the idea of how to provide service, and even as you're talking about some of this new space that you're working in now, this is we think this could be a better way of delivering services to people that need them. How are you kind of doing the education to the families, to the guardians, to the members themselves that hey, what you heard was the right way for all this time, it's changed, it's evolved. I mean, what effort are you doing to provide that education to change public understanding?
Well, we have evolved. And I think one of the spaces where our state fell short is that we didn't evolve fast enough, right? And so that's what brought DOJ to our state. And remember, this investigation is pointed to Glenwood and Woodward, but it involves every individual who has ID in this state. Every individual, and living in all institutional settings. So it's much broader than just Glenwood and Woodward. And what we relied on are brick and mortar spaces, right? That gives us certainty. It will always be there. It will be okay. And my loved one will be safe because they go there. What we've proven with Glenwood is that that's not always true. And you can see that even in some conversations or public displays of what's happening in nursing facilities for aging Iowans or Iowans with other types of disabilities. So brick and mortar does not equate to assurances that someone will be safe. And in fact, in some spaces, it provides more challenges. So really thinking about that, but there's no better way to hear about what the outside world can and does look like than those who have moved out of Glenwood and can tell their own story. So we use a lot of self-advocates. We rely heavily on guardians who have walked this journey. And I'm not a parent who has a child with special needs, at least not one that has presented quite yet. And so I don't have that journey. I do have a different journey with my own family members around needing to rely on institutional care and trying to transition to home-based and thinking about and fretting about, are they going to be safe? That's what every loved one struggles with. And so we're trying to provide all the assurances that safety can work. It just looks different. And that there is a new life out there. So those individuals, I mean, I'm thinking about one person right now who has tried Chinese food for the first person in this person's life because roommates at Glenwood couldn't have it. And now this person has, smiling and enjoying lo mein in a way that I know how delicious it is. But imagine being above 50 years of age and never having seedless watermelon. There's a bright world out there, and scary, but we're trying to show that world. So, and I recognize that these are really tough conversations for guardians because it is a shift, a marked shift, and that we have a huge responsibility to show them that we can do this in a way that does not at all invite risk, although there is nothing in life that doesn't come with risk.
Right. But well, everybody talks about government impacting or touching the lives of people. You're sitting at the helm of a department now that touches it in probably the deepest way of any, and so you're in the most personal and the most so understood to the lo mein and to the seedless watermelon.
Mhm, mhm.
We have another question that was submitted that says wages are clearly important. However, strategies are in place to provide high training standards, and are minimum training or CEU requirements in place? I think that
Training
goes
is a
back.
key component, yes. And you'll see that also, I failed to mention this when we were talking about managed care procurements, because the intent to have 3 is huge, right? But underneath that comes a rollout of contract changes in the base contracts that where you're going to start to see our commitment to quality, oversight, case management, et cetera, right? So further investment in making sure that our workforce is well trained and positioned to be doing this work as well. And that's an area where I think our agency has fallen short, but we are absolutely thinking about those bigger strategies and putting structure behind it to see it through.
In the preparation call that I had with Matt Highland, just to check my knowledge and make sure that I was understanding things, we had a conversation about kind of reviewing the waiver process, and maybe there are some changes in store, and I'm curious, I guess everything is up in the air and subject to change right now, but what work are you doing around the waivers?
So we have had a more than year-long evaluation of the gaps that exist for serving individuals who need long-term services and supports, and to rely on our 7 Medicaid waivers, acknowledging coming into this work that there were long wait lists in some areas. We kind of define them as interest lists because we know there's duplication, people who are on multiple wait lists for different services, and then individuals who are in the waivers but flipping to different ones to seek a service that isn't in the waiver they're in today. And so all together, it's our goal to support individuals, aging individuals who need long-term services and supports to thrive in their community of their choice, right? And so to do that, we need the mechanical structure of waivers that can actually provide that level of service and has the right rate structure to make sure service provision is in place. So that's what we set out to do. No small feat. We asked Mathematica, we did an open procurement, but Mathematica came on board to give us that extra layer of assistance in gathering feedback, and now in the financial and policy construction of what will be to come. So we're at the point where they are offering recommendations to me around how to restructure. Simplifying the waiver structures is key. Bringing down the wait list is the second objective. And then we will get to crafting that policy array that really does provide that level of service. Throughout this process, we've embedded providers, guardians, and our own clients, the members themselves, in this process. And that was a key part of what Director Matney wanted to see, and I fully embrace. So we've been really pleased with this work. I will tell you, there aren't many surprises in what Mathematica has found, but they are a solid gut check about where we want to head and exactly how to get there. And now we get to crafting.
For the outsider, when you say gut check, what are you
what are you
feeling? Yeah, what did you find?
So our waivers are too complex. 7 is too many. We don't have the right sets of services in the waivers to support someone living successfully at home, and people are instead overly relying on nursing facilities and other private institutions because they can't get what they need, like daily supports, to live successfully at home. And we have to do better there. So the next step will be, what services do we need? And Liz and I think we know what it is, but that's where we get the gut check from other expertise who can scan other Medicaid programs and give us a best practice solution. And then the financial modeling, which is complex, as you can imagine, to how to get there. And we really did hear from members themselves. What do you need?
And are you hoping to kind of work this path in parallel to those that we've talked about thus far? I mean, because I would imagine that change is hard, but you probably also want to limit the number of process changes and everything that you introduce.
Well, we've taken on a lot, as you've just identified throughout this conversation, but you're absolutely right, Zach. They're all working in concert together as part of an operational plan that is embedded in, where do we see the flaws in our system and how do we work to achieve shoring them up, really building out true access points, building out a true continuum of care, providing a front door entry point. So individuals who are giving birth to people today who have special needs can see where to go, or a family system that needs some help can see where to go, while using a really reinvigorating our design around public health strategies that serves all Iowans. We have some work to do in after action post-COVID. So deeply committed to that, and then using that model to inform the rest of the work. So all of it's happening together. It's a lot of work. It is. But we've got a team that's committed to it. They're reinvigorated. And we've got leadership, and all the way down to the folks on the very front line in our field work, as well as our facilities, who are part of that process every day.
Director, I have a question that's been submitted along the lines of COVID, but I also just wanted to ask in terms of, are things getting back to normal? We're in year 3 of COVID being present, but is some of with all of this work going on, is it possible, because COVID is now maybe not the distraction or the challenge that it was?
So we still work on COVID every day. That hasn't gone away. But it is not the force of an emergency response that it was a year ago. And yes, it has absolutely, I mean, we were doing this work, but we've been able to reprioritize, and that's needed, right? I mean, these are equal parts important issues that have been lingering and are impacting Iowans. And we can see that. We can see that in metrics and in data points. So yes, it has eased up on the bandwidth here a bit. Always a challenge though, right? Then we did monkeypox vaccine rollout. Our team members are always working on new strategies, and so that will continue, but it is a different force.
Okay. And the audience question that we had along these lines is, what are your thoughts on how to address the anti-vaccination trend that folks are encountering, especially, those that are yet to be vaccinated against COVID-19, but then also other concerns about other vaccinations as well?
Absolutely. We've seen our vaccine uptake across the board fall off, right? For all types of vaccines. And you can see this like in some other states with disease clusters that have not been prevalent in our lifetime popping up. And really around this notion of not vaccinating. So we have to rethink and reshape the way we're communicating. And we are breaking the models of the way that these types of conversations have happened historically. And so we are absolutely thinking about ways that we can better understand what that hesitancy is. So there is market research that's being done. We have to better understand what is driving that hesitancy, because it is different than anything we've experienced in kind of modern times. And COVID is that catalyzing event.
Mm-hmm. Well, I'm curious, are you seeing that trickle down as you're talking about all of these changes, across, the systems that you're trying to put in place? Is there a hesitancy, that's coming just out of the fatigue or out of the...
There's definite fatigue there too, right? So yes, I mean, I think it's a moment to really reshape and reflect. There are spaces where we're seeing hesitancy. I can see it in our Medicaid data with children in the state. And so we're thinking about how to re-engage in it. But some of that is that the uptick in accessing healthcare has not fully re-engaged to pre-pandemic levels, right? And so we have to reinvigorate that approach too, because outside of even the vaccine conversation, just going to the doctor or the dentist is step number 1. And we're thinking about all of those pieces and have to be thinking about all of those pieces. And there is definite fatigue. So we're also thinking about how to make sure that we are re-engaging with our workforce, both internal to the department as well as our external partners, because it has been, my goodness. I mean, when I think about November 1st, I will have been here 3 years. It both feels like 3 years and 3 months or 30 years, right? I don't know altogether. I mean, it has just been such a fast and furious pace and such a difficult time for everyone. So we're thinking about that too. We have to.
All right. Well, Director Garcia, I know that we're nearing the end of our time, and I just wanted to say thank you again for taking the time to join us with Iowa Ideas and your willingness to do this and to field questions. I appreciate that, and a lot of insights, and clearly no shortage of things pressing for your time. So thank you for for taking time to explain some of this, as well as just check in on other things. And so on behalf of the entire team here, thank you. And thanks to our audience. And so we will take a break, and it will be jump to other session time. But thank you, Director.
Oh, thank you so much. Appreciate it always. Take good care.
You too. Bye.
Bye-bye.